Hi friends, welcome back to my channel. Liver may be involved in pregnancy in various ways. Either it may be related to pregnancy or it may not be related to pregnancy. First, let me give you few examples with MCQs. So let's start with this clinical VNet. A 24-year-old pregnant lady with 30 weeks of gestation presents to the emergency department with complaints of repeated vomiting since last one day. She has no recent history of headache, seizures, or blurring of vision. Her vitals are as follows: heart rate 125, BP 165 over 110, respiratory rate 22 per minute, SpO2 on room air 97%, liver function test reveal bilirubin of 165 micromole per liter, aspartate aminotransferase of 700 units per liter, fibrinogen of 0.5 gram per liter, and a prothrombin time of 29 seconds. Her plasma her plasma glucose is 2.3 millimole per liter. Which of the following is the most likely diagnosis? So here we have various options which could be potential diagnosis. Now, to clinch our diagnosis from history and the laboratory findings presented in this question, we must begin our discussion with understanding of how do we classify hepatic disorders in pregnancy. There are three main categories of liver disorders seen in pregnant ladies, right? Few disorders are pre-existing in women as she becomes pregnant and comes to you. And these disorders could be chronic hepatitis or Wilson's disease or primary sclerosing cholangitis. There is second category which is quite familiar to all of you is the pregnancy specific liver disorders or pregnancy related disorders which de novo which occur first time, okay, and only arise as the complications of pregnancy. In this category, there are five main disorders: acute fatty liver of pregnancy, HELLP syndrome, intrahepatic cholestasis of pregnancy, hyperemesis gravidarum, and preeclampsia eclampsia syndrome. So these all disorders can occur in different gestational time periods. For example, hyperemesis gravidarum is most common in the first trimester. Okay, whereas acute fatty liver of pregnancy occurs usually in the last trimester of pregnancy. So there is a last and third category of liver disorders which are neither previously diagnosed nor related to pregnancy but acquired during pregnancy or detected coincidentally during workup, such as acute viral hepatitis, which may be acquired by any pregnant woman, right? So, for example, veno-occlusive disease like Chiari syndrome can also occur as a unrelated liver disorder to pregnancy. Various types of drug-induced hepatotoxicity or even sepsis are unrelated to pregnancy but can affect participant equally as any other patient. Coming back to our question, if you look at the history, there is no mention of pruritus. So pruritus is the main symptomatology of intrahepatic cholestasis of pregnancy, which is the most common hepatic disorder related to pregnancy in women. It usually presents in the late second and early third trimester of pregnancy. The main presenting symptom of ICP is the pruritus, which is quite intolerable or uncomfortable for the patient, and it is due to usually the high level of bile acids. So that disorders can be ruled out here. So this cannot be the cholestasis of pregnancy because another important fact here is that a bilirubin is usually less than 100 micromole per liter in cholestasis of pregnancy. So hepatic derangement is not so severe. Aminotransferase level would also be less than 100 and coagulation disturbance will not be seen in cholestasis of pregnancy usually. Okay, so this cannot be cholestasis of pregnancy. Now, because liver enzymes are not much elevated, viral hepatitis may also be ruled out. So viral hepatitis like hepatitis A, B, and C are sometimes noted during pregnancy, and mortality can be up to 30%, and fetal mortality can be up to 50% in such patients. Okay, and prognosis, as I said, is very grim in viral hepatitis C. So this can also be ruled out because aminotransferase level is not more than 1000. Now regarding the veno-occlusive disease, for example, Chiari syndrome, which presents with classic triad of abdominal pain, ascites, and hepatomegaly. These three findings are absent in the history in this question, so that can also be ruled out. So, few more words about Chiari syndrome. It occurs more frequently in the postpartum state rather than in the pregnant state, and this is usually diagnosed by the use of Doppler of the portal vein and ultrasound. Okay, on an ultrasound. And veno-occlusive disease, which is actually a type of Budd-Chiari syndrome, is also known as sinusoidal obstruction syndrome or SOS, which happens when the small blood vessels that lead to the liver and the veins which are inside the liver become blocked, okay, because of clot. Because pregnancy is a hypercoagulable state, and it provides an opportunity or a state where all the veins in the body can get occluded by the clots. Okay, so that same thing happens inside liver also, right? Now regarding the liver hematoma or hepatic rupture, which is a complication of hypertensive pregnant women, uh, can also be a possibility, but usually patients will be presenting with acute epigastric pain if they're conscious, okay, and if they're not conscious, they will present with hypotension and pallor, okay, because of hemorrhagic shock. Patient will present to emergency department. Now again, there is no enough history in in this question to suggest that patient has developed liver hematoma. Okay, so this possibility can also be ruled out. However, this can also be possibility if this history could have been there in this question, but we can safely rule out. Now, the most possible diagnosis here is, which is the diagnosis of exclusion, and from the question also, it is quite clear that it could be acute fatty liver or pregnancy because there is there are features. Okay, so in this question there is fibrinogen level which is low and performance time is high, so that shows that patient has developed acute liver failure. Okay, and also the hypoglycemia, which is also one more important sign in acute liver failure. Okay, so basically acute fatty liver of pregnancy is a type of acute liver failure. Patients will be presenting to you with disturbed consciousness. Okay, so that is hepatic encephalopathy, and also bleeding disorders, coagulopathy, and all the coagulation profile disturbances which you will see on the labs. So apart from that, other features of AFLP which are not described in this question are depressed consciousness, as I told you already, and you would like to see the ammonia level which would be high. Basically, FLP, as I said, is acute liver failure of pregnancy and it carries high mortality. And all these features which are listed here will be seen in acute fatty liver of pregnancy. Now, in this question, you will see that patient presented with repeated vomiting, which is a feature of hyperemesis gravidarum also. Okay, so remember, this could be a possibility because hyperemesis gravidarum is one of the five main pregnancy-specific disorder, liver disorder. So that could be a possibility, especially when patient presents to you with in the first trimester of pregnancy, not in the last trimester. So this option, if it would have been there in your choices of this question, could have been one, misleading option because the patient is presenting to you in this question in third trimester. So this possibility can be ruled out. So hyperemesis gravidarum is definitely not the answer over here. Okay, few more points. Mild aminotransferase elevation up to 200 units per liter is the most common liver disorder, liver abnormality, or you can say liver laboratory abnormality seen in hyperemesis gravidarum. And also you would see the increased ALP, okay, and also hyperbilirubinemia up to 4 milligram per deciliter. So hyperemesis gravidarum is one of the pregnancy specific or unique to pregnancy liver disorder, so that you must know. Right, now we will move to our next question. A 36 years old woman at 34 weeks of gestation is admitted to ICU with altered mental status, G11 over 15, and deep jaundice, right upper quadrant ultrasound reveals a enlarged Okay, so here this something is missing. So patient is also having right upper quadrant pain, right? So this is not properly typed over here. But definitely ultrasound reveals an enlarged grade 1 fatty liver. Which of the following is the most appropriate therapeutic intervention? So all these interventions are listed in these options. So this is the question regarding therapeutics. Okay, and the diagnosis is quite clear. This is actually an AFLP because patient has developed already deep jaundice and altered mental status, and also there is enlarged fatty livers. Okay, so this is quite clear diagnosis, and the treatment in AFLP is delivery of the fetus. So this is a specific treatment. Apart from that, you have to start your supportive management and resuscitative management also, but the delivery of fetus is one thing which will change the outcome. All right. So now this is the third question. Which one of the following statement regarding liver dysfunction in pregnancy is true? Ursodeoxycholic acid is the treatment of choice in ICP. ICP resolves with the fetal delivery to recur in 45% to 70% of subsequent pregnancies. The main risk in ICP is to the fetus. Okay, the fetal risk is the main risk. The most specific and sensitive marker of ICP is the serum bile acid level of greater than 10 micromole per liter. E all of the above. So this is the question for you. ICP, is defined as the pruritus. The main feature is the pruritus, and a specific biochemical abnormality on the in the labs would be elevated bile acid level, which is there in this questions option also. So you have to tell me which option is correct in the comment box. This question is for you all guys. Okay. So I'm going to conclude here with a remark that all the best to your examination, and you are free to ask any query if you have in the comment box, and I will keep on posting such questions. Okay, in my free time I will prepare and post on you here on YouTube. So bye bye, take care.